all, my name is Daniel Bergenov, and I'm a first year PhD student at the Institute of Pharmaceutical Sciences, King's College London. Today I'm going to talk about methadone related mortality in England during the first national lockdown due to the COVID 19 pandemic. Opioid substitution therapy, or OST, with methadone or buprenorphine is a standard treatment for people dependent on opioids. Following the UK lockdown in March 2020 due to the COVID 19 pandemic, clinicians were advised to move patients from directly supervised consumption of methadone to 2-week take home prescriptions. This was due to concerns about access to OST if pharmacies were too close or have reduced opening hours due to pharmacy staff illness, and also to support the stay at home message for this patient group who often have a range of health comorbidities related to their previous opioid drug use. The aim of this research was to evaluate the impact of this change in the dispensing of methadone on methadone-related mortality in England. This was achieved by extracting and analyzing deaths reported to the National Programme on Substance Abuse Deaths where methadone was detected, and which occurred from March 23rd to June 22nd in 2020, and also for this same time period in 2016 through 2019 for trend comparison. Ethics were not required for this study as data privacy laws do not apply to deceased individuals. You can see a gradual increase in methadone-related deaths over the course of the study. However, we have predicted, based on the previous reporting trends, that in 2020 a total of 206 cases will be reported, which is an increase of 165% in comparison with 2019. When delineating by source of obtainment, the proportion of dissidents prescribed methadone increased by 5% between 2019 and 2020, which is in line with the average increase of 7% in the preceding years. However, a 51% increase in deaths where the detected methadone hadn't been prescribed was observed between 2019 and 2020, which is far greater than the 11% average increase in illicit methadone-related deaths in the preceding years. To conclude, the switch to take-home methadone prescriptions hasn't affected mortality rates in individuals prescribed methadone. However, deaths where methadone was illicitly procured have increased, likely due to the diversion of prescribed take-home methadone. Greater monitoring of those who are in treatment is required to reduce harms of those people who are out of treatment. A more nuanced approach to take-home dosing should be further explored. I would like to thank my supervisor, Dr. Caroline Copeland, and colleagues who made a contribution to this research. Thank you for your attention, and if you have any questions, please do not hesitate to
The
ask.
title of this presentation is Correlating Income with Opioid Prescription Dispensing Among Public Drug Plan Beneficiaries in Canada between 2010 and 2018, a population-based analysis. This study aims to examine the relationship between socioeconomic status as measured by the area-level median household income and the level of opioid dispensing in Canada, as well as to look at the trend of this relationship between socioeconomic status and opioid dispensing in Canada. We use the National Prescription Drug Utilization Information System, which includes all dispensing for all patients in Canada who are covered by the public drug plans, which is mostly people who are 65 and more, and we use data from 2010 to 2018-19 fiscal year. We receive data in the aggregate form, which are aggregated by jurisdiction, as well as the patient forward sortation area, which are the first 3 digits of the postal code. And this area is about 15,000 people neighborhood. We converted all of the doses of opioids into the morphine dose equivalent, and then we calculated the annual rate of how much morphine dose equivalent per capita in that area, in that income quintile in each year. We found that there was a close relationship between the income level and the dispensing rate of opioid. As you can see here, the highest income, which is quintile number 1, has the lowest dispensing rate at 23.21 morphine equivalent per capita, as opposed to the lowest income quintile, which is quintile number 5, which has 58.31 morphine equivalent per capita. When we calculated the rate ratio on the figure on the right, you can see that there is a close dose response relationship where the lowest the income is, the more rate ratio you have. So 2.51 rate ratio between quintile 5 and quintile 1. Over the study period, this rate ratio between the lowest income area and the highest income decreased slightly from 2.66 to 2.27, and this trend was significant. Nevertheless, it is still, as of 2018, a big difference in opioid dispensing between low income areas and high income areas, where people who live in lowest income areas receive more opioid prescriptions.
We know around about 25% of pregnant women will use an opioid during pregnancy and 1% will utilize methadone. Trying to engage women in treatment services is important through the perinatal period to ensure that mothers get optimal treatment, but also to enhance their engagement with treatment services and exposure to healthcare professionals. But we know that methadone levels can decrease throughout gestation. But trying to understand this is quite challenging because recruiting pregnant women into clinical studies is really complicated. So what we've done is to utilize an approach called physiologically based pharmacokinetic modeling, which simulates the physiology of an individual and also a population through a technique called virtual clinical trials. And we used virtual clinical trials to help us derive an optimal dosing schedule for methadone throughout the perinatal period. This approach breaks the human body down into smaller boxes or compartments. Each compartment has a physiology and is linked to relevant blood flows. And using mathematical modelling and this approach, we're able to develop a model that can predict the temporal changes in methadone levels over time, whilst also simulating the inter-individual variability that we see in the physiology and methadone concentrations across a population. We did this by using 14 retrospective clinical studies to both develop and validate our model to ensure it was robust to use. And during its application, we looked at methadone levels both in pregnant mothers, but also at term in fetal cord concentrations. We then derived and developed a dosing approach based upon a defined therapeutic range for methadone, both in pregnant women and also fetal cord concentrations. We were able to show that methadone levels decrease throughout gestation for R and S methadone. We can see it here in the graph with green and the red for peak and trough levels. And essentially we saw a 47% decrease in methadone trough concentrations compared to baseline, which are non-pregnant mothers. And this equated to 74% of our mothers having subtherapeutic concentrations, primarily because of the volume expansion that we see in the mother, but also the increase in drug metabolism. So in order to derive a revised dosing approach, we utilized existing targets, so typically doses of about 60 to 90 milligrams once a day. So if we took the example of 90 milligrams once a day pre-conception, by the end of trimester 1, we have to target a dose escalation up to 110 milligrams, and we can do this in 10 milligram weekly intervals. Trimester 2, we have to reach around about 120 to 140 milligrams, and by trimester 3, we can reach up to 180 milligrams. And by doing so, we were able to decrease the number of our patients having subtherapeutic concentrations by around about 50%. Using this revised dosing approach. We also demonstrated two tapering approaches, a fast and a slow tapering approach, depending on the level of body fat in the mother. And in conclusion, methadone doses must be revised and reviewed throughout gestation. Dose increases are required, but using this particular approach, we were able to demonstrate how we can achieve this dosing approach.
The aim of this research is to determine the feasibility and acceptability of long-acting buprenorphine within community substance misuse services. WDP is a community substance misuse service provider and launched the long-acting buprenorphine pilot within Redbridge in 2019. Service users were offered long-acting buprenorphine as an alternative to traditional forms of buprenorphine and methadone medication. 31 service users have been offered long-acting buprenorphine, and WDP practitioners, clinical staff, and local pharmacy are involved in the delivery. WDP's Innovation and Research Unit used descriptive statistics and thematic analysis to analyse service user and staff experience of the pilot. Quantitative data was captured from WDP's case management system and service user satisfaction surveys. These surveys, combined with staff focus groups and pharmacy feedback, also acquired qualitative data. Key findings include 25 service users, 81%, commenced and continued using long-acting buprenorphine. 6 service users did not. When compared to traditional forms of medication, 12 out of 15 service user respondents in a satisfaction survey rated long-acting buprenorphine as significantly or somewhat better than traditional medication. The research also identified that long-acting buprenorphine successfully works for service users who are complex, new to treatment, and stabilized. Service users looking to reduce may not find this appropriate. The key reasons for engagement retention identified by service users and staff included convenience and freedom. One service user identified, "I can carry on with life without being tied to the chemist." Reasons for disengagement included service users using on top and service users wanting to detox from all opiates and medication. Some disadvantages identified around long-acting buprenorphine include some side effects such as nausea, knee jerk, and sweating, and the pain, fear, and triggering nature of injections. Some staff also raised concerns about service users not wanting to engage in psychosocial support. Despite these disadvantages, all service user respondents stated they would recommend long-acting buprenorphine. One service user stated, "Go for it, better than all others." WDP staff also endorsed the long-acting buprenorphine pilot, and the local pharmacy identified that they had never seen such high rates of service users seizing in the 35 years of practice in OST. Redbridge Commissioner also stated and endorsed the long-acting buprenorphine pilot, stating that long-acting buprenorphine deepens choice and offers freedom for service users and supports with individual recovery. In conclusion, service user and staff experience has been predominantly positive, and WGP will continue to offer long-acting buprenorphine to service users meeting the eligibility criteria.
This is a recording of It's a Saviour, clients' experiences of commencing on long-acting injectable buprenorphine. I'm Jan Melekar and I'm presenting this. We're looking at using long-acting injectable buprenorphine or Buvidal in Wales. We've used it in over 1,000 patients. It's been fantastic. This is some thematic work around that. We took 8 participants. We gave them an interview, semi-structured at time 0, after 1 week of a weekly injection. We then switched them immediately to a monthly injection, and after the first monthly injection. Second slide. The results were put out in 4 separate viewpoints. First of all, the positive impact of life. I'll best read it out. I haven't used the tool. It's not in my head to use when I wake up in the morning. It's not even in the thought pattern. The second thing, challenging experiences. It's fine, but your emotions start coming back, which is hard sometimes because you end up a bloody crying mess. Holistic support. I think with anything, it's helpful to talk to people who've experienced the same thing in some degree or other. And finally, long-acting injectable buprenorphine promotion. I would recommend it. I just think it's like a magic thing. I mean, it's been amazing for me. It saved my life and, you know, my son's life. Third slide. Okay. People really commencing long-acting injectable buprenorphine felt that there were significant positive changes. They far outweighed any challenges. The clear-headedness, the being able to have a normal life, the breaking rituals, just brilliant. It seems to genuinely fast-track people into recovery. There may be more support needs over time, but looking at what we found and what we are finding, we have the following recommendations. First and most importantly, that there's a stepped approach to psychological support. Starting at the bottom, some people genuinely need no additional psychological support. Then some need safety and stabilization, brief interventions. This is the stuff most key workers are trained to do and then forget to do because of the chaos of prescribing. They're able to do that now. It's wonderful to see everyone engaging well. Then there's the guided self-help, trauma, psychoeducation, and around things for anxiety and low mood. And finally, proper psychological therapy, which is wonderful to work with because they're able to engage, because they're stable on the Buvidal. They're not sedated. They're not thinking, how long have I got before I run out? Other options are preparation checklists and peer support. And obviously, we wouldn't be a clinical research unit if we didn't say future research. But honestly, long-acting injectable buprenorphine, it's been a game changer. I've been researching in this area for 25 years, and I've never been so happy to present this research. Thank you.
This piece of work is the use of long-acting buprenorphine in drug crisis admissions in Glasgow. Glasgow Drug Crisis Centre is a 12-bed facility offering a 21-day stay for individuals with high-risk dependent drug use likely to cause them significant and imminent harm. It can be accessed directly from the community and offers extensive health supports, including opioid substitution treatment or OST. This was previously limited to methadone or oral buprenorphine, but recently expanded to include long-acting buprenorphine or LAB, something which had been shown to have notable benefits in Glasgow community teams but had not been used in a crisis setting before. All admissions to the service were offered all OST options equally, including LAB. Pre-existing OST of a different kind, such as methadone, did not preclude this as an option. Outcomes were measured 3 months after discharge. During the first 6 months of being offered, 19 of the 151 admissions opted for LAB. Of these, the vast majority completed their planned stay, and 3/4 were retained on LAB treatment at the 3-month mark. There was a reduction in reported drug use of all kinds by 89% in the 3 months post-discharge, and for IV use this reduction was even higher at over 90%, which has clear implications for public health, especially when considering the spike in HIV cases in Glasgow among the injecting group noted over recent years. When looking at structured activities, so things like engagement with recovery supports or training, none of the participants were engaged prior to admission. This rose sharply to almost half of them in the 3 months after discharge. One of the most significant findings of all was the reduction in non-fatal overdose. From there being 13 overdoses in the group prior to admission, there was only a single non-fatal overdose recorded in the group in the 3 months after discharge. Not only is this statistically significant, but given that non-fatal overdose is a strong predictor of future fatal overdose, this finding is of considerable significance when considering rising numbers of drug-related deaths in Scotland. In conclusion, long-acting buprenorphine used in a crisis setting was shown to be highly effective in every measured outcome, with the most significant being the reduction in rate of overdose. The outcomes will continue to be measured at 6 months and beyond, and this process will be further developed into service guidance. Thank you for listening, and I'm happy to be contacted with any queries.
Hello to everyone, my name is Mauricio Quesada, and I'm a candidate for a Doctor of Science and Innovation in Medicine. Our work is titled Oral Voluntary Morphine Consumption in Female Wistar Rats Accustomed to the Veterans, Model Development and Validation. The non-therapeutic use of opioids, such as morphine, resulted in a high morbid mortality that has continued to increase in the recent years. Once the dependence on opioids is generated, the patient can relapse to its consumption in 2 ways. One of them is the memory of the gratifying sensation mediated by the pathological association of these effects with the presence of environmental stimuli, characterized by the activation of the reward system. Normally, when patients with drugs dependence try to stop their consumption, a deprivation syndrome is generated that can be approached with clinical support. But particularly in the case of opioids, physical dependence is severe, leading to an urgent need to re-administer the drugs. Both processes involve the presence of oxidative stress and inflammation. Current therapy consists of the substitution of the opioid for another. The idea is that opioids with a very short half-life are replaced by an opioid with a much longer and safer half-life, but its availability is highly regulated, which makes it difficult to cover the treatment. The intention of this therapy is to gradually reduce the dose of opioids, and that in most cases is not achieved, and the patient simply ends up changing one addiction for another. This prompts the search for a new therapeutic option, but first animal models that adequately mimic this stage are required. That is why we have developed a voluntary consumption model for which it was necessary after weaning Wistar rats were subjected to early being access to a bottle with quinine dissolved in water or bottle of water, according group. 8 days later, the bitterness of quinine. A second bottle with morphine was given to experimental rats and voluntary morphine injected was evaluated. Finally, the quinine was removed and experimental rats were exposed to a 2-bottle choice between water and morphine. Following this protocol, 65% of the experimental rats voluntarily drank morphine and maintains a 19% preference for 4 weeks, even after quinine removal. Analgesia was measured through the bone frame test and Harvard plantar test. Hyperlocomotion was measured through open field tests, and withdrawal syndrome induced by morphine were studied through a validated score. Hippocampal oxidative stress test was also evaluated. Additionally, the experimental showed a greater effects of mechanical and thermal analgesia, as well as an increasing hyperlocomotion and high deprivation syndrome. versus the control group. In parallel, an increase in hippocampal oxidative stress was observed. Neuroinflammation tests are still under development. This animal model offers the possibility of testing new drugs with therapeutic potential to reduce the voluntary consumption of opioids following chronic opioid use. The method as described does not require the use of a prior parental administration of morphine. Thank you very much for listening.
Hi, I'm Trina Ritchie, lead clinician in Glasgow Alcohol and Drug Recovery Services. I'm delighted to share our progress in Glasgow with our OST prescribing work towards Standards 1 and 2 of the Scottish Government's MAT standards. For this work, we used our drug and alcohol treatment waiting times returns as our data source to ensure we included all referrals involving opioids. In the service, we work across a number of IT systems, which complicates clinical audit. Each audit cycle involved manual examination of electronic patient records. The initial citywide audit in 2020 was undertaken to ensure that pandemic contingency measures were effective. We were reassured by the 75% uptake of OST and that almost half of people started OST within 3 days. The audit also, however, highlighted operational challenges which were addressed by development of a standard operating procedure. The areas of improvement focused on adopting an outreach approach on the day of referral, considering the use of taxis when necessary, and streamlining roles, tasks, and communication. Re-audit in January was anticipated to show improvement. However, the results, including no same-day starts, showed that due to competing priorities, the SOP had not yet been fully implemented. The most recent audit cycle shows significant improvement from both previous audits, with 70% of people starting OST within 3 days. The people who do not start within 3 days tend to be people who are referred by a third party rather than people who self-refer for treatment. MAT Standard 2 focuses on choice of OST medication with the recommendation that all be offered equally when clinically appropriate. In May 2020, over 2/3 of people in Glasgow were commenced on methadone, although oral and long-acting buprenorphine were also offered. By the 2021 audits, this had significantly changed to around only 1/3 of people choosing to start OST methadone. This reflects a cultural shift in what has traditionally been a predominantly methadone prescribing service. Staff are increasingly confident in discussing buprenorphine as a treatment option, in particular with reference to its safer profile in the first weeks of treatment, and also safely managing buprenorphine initiation in people who are not currently demonstrating opioid withdrawals without introducing unnecessary barriers to treatment. Crucial when street benzodiazepine use may be masking withdrawals. In conclusion, we demonstrate the critical role of clinical audit in service development and quality improvement. We will continue with regular audits and are aiming to develop an electronic audit process, although the information from manual interrogation of records has been invaluable. Thank you for listening.
Hi, my name is Kirsten, and my poster is on investigating trends in dihydrocodone-related deaths in England. Dihydrocodone is an opioid analgesic. In England, it is licensed as a prescription medication for pain relief, and it's also sold over the counter, or OTC, in lower strength preparations with paracetamol called codidromol. The potency of dihydrocodone is 1/10 that of oral morphine, but it has been identified in accidental overdose deaths with other central nervous system depressants. The aims of our study were to analyze trends in dihydrocodone-related deaths in England over a 20-year period and to identify the risk factors and motivations of dihydrocodone misuse. We extracted cases with dihydrocodone from the National Program on Substance Abuse Deaths, or NPSAD, that occurred between 2001 to 2020 and were reported to NPSAD by the 31st of March 2021. Cases were then classified by the source of dihydrocodone obtainment for further analysis. We found a total of 2,071 dihydrocodone-related deaths in England that were reported to NPSAD over 20 years. As you can see in Figure 1, overall, the number of deaths reported to NPSAD has not considerably changed over time. However, when delineating by source of obtainment, there was an increase in deaths from illicit dihydrocodone in Figure 2. We also found that 95% of the deaths from illicit dihydrocodone and 89% of deaths from OTC codidromol occurred in combination with other central nervous system depressants. With illicit dihydrocodone, we identified opioids in 68% of cases and hypnotic sedatives in 57%. OTC codidromol cases had a similar proportion of additional opioids co-detected, but hypnotic sedative co-administration dropped to 27%. Furthermore, the source of these co-detected opioids and hypnotic sedatives in both OTC and illicit dihydrocodone cases were determined to be illicitly obtained in the majority of these deaths. Suicides accounted for 43% of OTC codidromol deaths, in contrast with 19% of illicit dihydrocodone deaths, which is a greater than twofold increase in suicides. OTC codidromol decedents were also older, and a smaller proportion of decedents had a history of drug misuse. From this data, two trends emerged. The first is that the high rates of poly drug use with illicit dihydrocodone is leading to an increase in accidental deaths. Spreading awareness to people who use drugs on the harms of poly drug misuse is needed to reduce accidental overdoses in this population. Second, OTC codidromol is being deliberately sought out for fatal self-poisonings at alarming rates, and a safety review of this medication is urgently needed to determine if its benefits continue to outweigh the risks of overdose. A limiting factor of this study is that reporting of drug-related deaths to MPSAT is voluntary. Therefore, the alarming data presented here is likely an underestimate of the total number of dihydrocodone-related deaths in England. Thank you for listening.
Hello and welcome to this poster presentation. My name is Dr. Craig Sayers and I have been the clinical lead for prison healthcare within the NHS Forth Valley area for over 10 years. The poster is an interim output of a joint working project between Cameras Limited and NHS Forth Valley. The objective of the joint working project is to conduct a service evaluation to assess the use of prolonged release buprenorphine in custodial settings in the Forth Valley Health Board area. As part of the Scottish Government COVID pandemic response, a directive was issued to Scottish prisons at the end of April 2020 that patients could and should be converted from their current opioid dependence treatment to prolonged release buprenorphine in the form of Buvidal. Since that time, 117 patients have been initiated onto prolonged release buprenorphine within NHS Forth Valley prisons. Of these 117 patients, 80 have converted to Buvidal from a previous methadone prescription. HMP Glenorchy is one of 3 prisons included in the project. Considering prison transfers and liberations, Glenorchy has on average 45 patients at any given time receiving Buvidal. A time analysis of nurse administration for methadone and Buvidal was carried out, with significant nursing time efficiencies noted, which can be directed to other nursing duties. The 5,040 and 1,080 minutes mentioned on this slide are based on that average of 45 patients receiving Buvidal. Treatment satisfaction for medication data was collected at 4, 12, 24 and 52 weeks. Global TSQM scores show a high level of patient satisfaction outcomes with scores in excess of 80. If we look specifically at the patients who we've transferred to Buvidal from methadone, we see high levels of patient satisfaction throughout, but there appears to be a greater satisfaction score for patients who converted from an initial dose of methadone 30 milligrams daily or less, when compared to patients who underwent a reduction to 30 milligrams from higher doses of methadone prior to conversion. A Likert score was carried out between 2 to 4 weeks and at 12 weeks for patients who converted to Buvidal from other opioid dependence treatments. These results show a high level of patient satisfaction with Buvidal when compared to previous treatments, with a greater satisfaction being recorded after a more prolonged period in treatment.